Welcome to the proceedings of Day 2 of WCCPCI 2016, the 11th World Congress on Clinical Preventive Cardiology and Imaging. We are on the 23rd of September 2016 on this auspicious day of Friday. Ladies and gentlemen, welcome to the session 1, that's on atrial fibrillation track, New Frontier. And we've got, as of now, 2 of our speakers available. Both of them would have 20 minutes each back to back, and then we'll have the last 10 minutes or so for discussion. We'll reserve the comments of the chair and the discussion at the end of the entire set of lectures. With these few words, to help the speakers be on time, we have a timer adjacent to the plasma screen on the podium. May I request them to kindly pay attention. At the end of the stipulated time, we'll have a time-up slide without any further extension to help us be within the ambit of time. With these few words, soliciting the cooperation of the speakers and the chairman, I'd like to invite our first set of chairpersons. Please welcome, in the order of appearance, Professors P.C. Manoria, H.K. Reddy, Drs. Rakesh Sharma, P.K. Gupta, S.K. Agarwal, Amrish Agarwal, and Sister Harvinder Kaur. And our opening speaker of the morning is Professor Sumitra Roy. He is currently an Executive Council member of the Cardiological Society of India. He serves in his capacity as a Professor of Cardiology at the Vivekananda Institute of Medical Sciences. He is a Senior Consultant Interventional Cardiologist at Woodlands Hospital and Sri Aurobindo Seva Kendra from Kolkata in West Bengal. This morning, Professor Roy joins us to speak for the next 20 minutes on NOAC in NVAF Status 2016.
Good morning, everybody. The first session today is on atrial fibrillation. And as we know, atrial fibrillation poses 2 major challenges. One, control of rate by rate control or rhythm strategy, and prevention of stroke, which is a devastating complications. Rate can be controlled by drugs, AB nodal modification or AB nodal ablation with PPI, and rhythm can be controlled by electrical conversion, pharmacological conversion, or radiofrequency ablation. And stroke can be minimized by oral anticoagulants, NOACs, and left atrial appendage closure device or surgical closure of the left atrial appendage. We will have the first session by Dr. Sumitra Roy on NOACs in non-valvular atrial fibrillation. Dr. Roy, please.
Okay. Thank you and good morning, respected chairpersons, my colleagues, friends, brothers and sisters. We start by saying Om Shanti as we learned yesterday so well. Today's my subject, I'm starting with NOAC, that is novel oral anticoagulant in non-valvular atrial fibrillation, status 2016. We know that warfarin or VKA is the gold standard for anticoagulation in cases of atrial fibrillation, both valvular and non-valvular. And we all know the various problems while using warfarin or keeping the patient adequately anticoagulated. The most important problem is crystallized by one value or one parameter, that is INR control. And if we see in this study, which is a sub-study from the RELY trial, that in India, of all the patients who are taking VKA, only about 1/3 are in the therapeutic range at a given point of time. They are either below the range or above the range. And you know the problems if the patient is below the range. There is a steep rise in ischemic stroke. And if the patient is above the range of INR, then there is again a steep rise of hemorrhage, particularly intracranial hemorrhage. So the basic purpose of serving the patient is foiled unless we keep a proper INR while treating the patient with oral anticoagulant. And that is the main problem of using VKA or warfarin type of medicines. And why this variation occurs of INR? And there are lots of factors behind it. Because warfarin is perhaps the only drug so far discovered in the medical armamentarium which does not have a dose. Its dose or its daily requirement depends on the thinness or thickness of the blood. It has got no dose for any particular person or any particular setup. So, of course, that is not a very handy tool to operate on a day-to-day basis. It may be good in experimental setup when patients are highly motivated, doctors have all the time to do the research, and there are huge infrastructure, and most of these are free of cost. So what we need as a working drug is an improved oral anticoagulant which should have the following characteristics of good bioavailability, minimum interaction with food and drugs, quick onset and quick offset of action, wide therapeutic range, predictable response, an antidote should be available in case of an adversity, and no untoward or unexpected toxicity. So scientists worked, they have been working for a long time, and they have identified two areas where we can intervene to achieve, if not all, but some of the above characteristics of a desired oral anticoagulant, and those we collectively called novel oral anticoagulant. It's no longer novel because they are almost 10 years now in market. So now they are called non-VKA oral anticoagulant. That is non-vitamin K antagonist oral anticoagulant. So that is the new terminology we are using. So where exactly in the coagulation cascade these may work? There are two broad categories. One is factor 10A inhibitor and another is direct thrombin inhibitor or DTI. In the DTI group we have got dabigatran is the only member, and in the factor 10A inhibitors we have got three members: rivaroxaban, apixaban and edoxaban. And of course there are other members in the pipeline. Now my subject heading is non-valvular atrial fibrillation, role of oral anticoagulant. So I must define first what is non-valvular atrial fibrillation. You see, this is again not a very standardized terminology. In different clinical setups where these novel oral anticoagulants have been tested, they have defined non-valvular AF differently. Like for example, take dabigatran, where history of heart valve disorder, prosthetic valve or hemodynamically relevant valve disease were excluded. For rivaroxaban, the ROCKET AF trial, whom they excluded, hemodynamically significant mitral valve stenosis and prosthetic heart valve. Whereas annuloplasty with or without prosthetic ring, commissurotomy or valvuloplasty were permitted. So they were not non-valvular AF. In Aristotle trial, the flagship trial of apixaban, they excluded clinically significant mitral stenosis and conditions other than atrial fibrillation that require chronic anticoagulation like prosthetic mechanical heart valve. So what the three major trials more or less agree is that prosthetic mechanical heart valve, they are out and out the valve disease. So the question of oral anticoagulation, the novel ones, are not coming in this setup. So the native valve disease, here, now in 2016, both Europe and American authorities have agreed that moderate to severe mitral stenosis is not permitted to be treated with newer oral anticoagulant. So these two groups are exclusively for warfarin. All other so-called valve disease, aortic stenosis, aortic regurgitation, tricuspid regurgitation, mitral regurgitation, pulmonary valve disease, bioprosthesis, they are all permissible under the purview of oral anticoagulant, the newer ones, as long as there is no other contraindication. So this has to be implied at the beginning that non-valvular atrial fibrillation is a big terminology. If we glimpse very quickly into the three major trials and see where is the Indian perspective in these trials, whether there is any, we know that RELY trial tested dabigatran, and it was published in 2009, and they tested 2 doses of dabigatran, 110 milligram twice and 150 milligram twice, against dose-adjusted warfarin to keep the INR between 2 and 3. And their primary objective was to establish non-inferiority of dabigatran to warfarin with at least 1 year follow-up. And India contributed 2,520 patients from 22 centers. So actually, there is a good representation of Indian population in this trial of 15,000 patients. 2,000 is not a bad number. So you can say whatever is the conclusion in RELY can be extrapolated or can be applied to Indian scenario. And what was those conclusions? The conclusions were that the primary efficacy, the vascular mortality, 110 milligram twice dose is equivalent to warfarin. It is non-inferior. Whereas 150 milligram twice dose is actually superior to warfarin as far as the total mortality is concerned. The question comes, okay, if efficacy is okay, what about the side effects? There also it wins. It shows that dabigatran 110 or 150, in younger patients, they are very much superior compared to warfarin as far as the major bleeding is concerned. Only in 150 milligram twice dose, if the patient is above 75 years of age, there is an increased trend of bleeding against warfarin. But 110 milligram twice a dose is equipoised with warfarin. So maybe if the person is above the age of 75, you should consider twice, think twice before giving NOAC. And if you choose NOAC, you better go for a lower dose. That is the message from this trial. So they concluded, for stroke and major bleeding, both doses of dabigatran provide advantages over warfarin, keeping an average TTR of 64%. Time in therapeutic range. That means how many times the patient's INR is between 2 and 3. And in an experimental setup, it is 64%. In our day-to-day practice, it is not more than 30 to 40%. So whatever result we are seeing here is actually tilting in favor of warfarin. In our clinical practice, warfarin is even worse performer. 150 milligram BD is superior in efficacy with similar major bleeding. 110 milligram BD is non-inferior in efficacy with less major bleeding, and both doses provide less intracranial bleeding. These results were consistent irrespective of the tendency to bleed or the stroke, center's quality of INR control, and patient's prior history of stroke or TIA. For secondary outcome, advantages of dabigatran were greater at centers with poor INR control than at those with good INR control. Maybe the whole India can be taken as a center of poor INR control, excepting in a few corporate hospitals. But dabigatran has its own bane, particularly two. One is GI bleed, one is myocardial infarction. But both were somewhat neutralized in big registries from US Insurance Registry, US Veterans Registry, and Danish Population Registry. All three registries, in hindsight, said that MI, if anything, is less with dabigatran compared to warfarin, it's not more. And GI bleed is definitely high, but if you choose your patient who do not have a history of peptic ulcer disease or do not have a tendency for GI bleeding or frail patient, perhaps you are playing safe. But you have to be careful. And it is not a peptic ulcer bleed what happens with dabigatran. It's some sort of duodenal or jejunal bleed. So it is very difficult once it starts. With that note, we leave dabigatran and come to Rocket AF with rivaroxaban. Again, we see in India there was 269 patients were from India. It's not a very big proportion, but India was represented in this trial as well. And what they found, that efficacy outcome, everything was slightly in favor of rivaroxaban compared to warfarin. Stroke, ischemic stroke, hemorrhagic stroke is hugely in favor of rivaroxaban, infarction and all-cause mortality. Whereas ICH is hugely in favor of rivaroxaban and major bleeding is almost at the center. If we see the primary efficacy outcome of stroke and non-CNS embolism, rivaroxaban is significantly non-inferior. I'm not saying significantly superior, but in the non-inferiority trial, it stands very highly. So it is really non-inferior. That is the conclusion. Primary safety outcome, if you see the p-values, there is no difference. So it is as safe or as unsafe as warfarin, however you look into it. So they summarize, rivaroxaban was non-inferior to warfarin for prevention of stroke and non-CNS embolism. By intention to treat, rivaroxaban was non-inferior to warfarin but did not achieve superiority. Whereas 150 milligram BD dose of dabigatran achieved superiority. Safety, similar rates of bleeding and adverse events, less ICH and fatal bleeding with rivaroxaban. So they concluded rivaroxaban is a proven alternative to warfarin for moderate or high risk patient with AF. The third agent is apixaban, which is again a factor 10A inhibitor, and the prototype trial was Aristotle trial, where here there is some peculiarity that they predetermined 2 doses depending on patient profile. Though the standard dose was 5 milligram twice, but 2.5 milligram twice was selected for patients who have 2 of the 3 criteria, that is age above 80, weight below 60, and creatinine above 1.5. If 2 of these 3 are fulfilled, then the intention to treat dose was 2.5 twice and not 5 milligram twice. And apixaban was proved to be superior, not non-inferior, to warfarin in preventing stroke or systemic embolism, and p-value is clearly indicating 0.01. And major bleeding also, apixaban is clearly superior to warfarin with a p-value less than 0.001. Actually, apixaban demonstrated superiority versus warfarin in terms of primary efficacy, major bleeding, and all-cause mortality. All the 3 parameters that we want in a new oral anticoagulant. And the impact they have secondarily analyzed about a few years ago. For every 1,000 AF patients treated for about 2 years, apixaban as compared with warfarin prevented 6 strokes, 15 major bleeds, and 8 deaths. And mind it, that is a very highly structured experimental setup where warfarin was tightly controlled with the INR keeping between 2 and 3. So in the general population, you can perhaps expect these figures to be doubled at least. And lastly, the Engage AF TIMI48 trial, which again with edoxaban, with 2 doses, 30 and 60 milligram, and it showed 60 milligram daily and 30 milligram daily were non-inferior for stroke prevention in patients with AF compared with warfarin. And edoxaban resulted in a significant dose-related reduction in bleeding when compared with warfarin. Although high-dose edoxaban resulted in excess GI bleed, again like dabigatran. We feel concerned about treating patients of AF with renal failure, and here is a summarized version of the comparative of these 4 agents. If we see the renal clearance is very high with dabigatran and which is quite low with rivaroxaban and apixaban, edoxaban has got a balanced clearance. Number of patients we have known in these trials, those we have already discussed. Exclusion criteria for CKD. So perhaps this exclusion criteria we should also apply to our patients. Creatinine clearance below 30 ml per minute, we should not go for NOACs. We should stick to warfarin by controlling the INR. Maybe for apixaban, it's slightly lower, 25, but it really doesn't matter, 25 and 30. Better to keep one figure in mind, that creatinine clearance below 30, we should not use NOAC as a first choice. Dose adjustment with CKD. For dabigatran, no dose adjustment is required. For rivaroxaban, between 30 and 50 ml creatinine clearance, reduce the dose by a notch from 20 to 15. For apixaban, we already have preset dose of 2.5 twice rather than 5 twice. And for edoxaban, you reduce the dose by 50%. If you contemplate 60, give 30. If you contemplate 30, give 15. Percentage of patients were not low in those big trials, somewhere between 15 to 20%. So they were in a position to give this diktat or give this advice. Reduction of stroke and systemic embolism, there is no interaction with CKD status with dabigatran and almost everybody. So you reap the same benefit in CKD patients, but you have to be careful in adjusting the dose in special cases. In major hemorrhage also, the benefit is the same. So I'm coming to the last part of my presentation, last 2-3 minutes. In 2014, ACC-AHA guideline shows that antithrombotic therapy based on shared decision-making discussion of risk and stroke is patient's preference is class 1 indication, and warfarin recommended with mechanical heart valves. Target INR intensity should be based on the type and location of prosthesis. Whereas with prior stroke, TIA or score above 2, oral anticoagulant recommended, and the options include warfarin or dabigatran, rivaroxaban, apixaban, all are class 1. I won't dwell on 2014 because we are in 2016. I'm coming to my last slide, and just before passing, I would say that the hard criticism that NOACs don't have any antidote is going off because antidotes are coming up, though not so easily available, but they are coming up, both for the direct thrombin inhibitor and factor 10A inhibitors. My last slide is published 1 month ago at the ESC, that AF guideline 2016 by ASC, which makes some very interesting observations and comments which I want you to take through. Oral anticoagulant therapy to prevent thromboembolism is recommended in all male patients with CHA2DS2-VAS score 2 or more, and in all female patients with CHA2DS2-VAS 3 and more. If we come to line number 5, at 6 and 7, we get some very interesting data. VKA with INR 2 to 3 is recommended for stroke prevention in AF patient with moderate to severe mitral stenosis or mechanical heart valve. And very, very interestingly, see the next statement. When oral anticoagulation is initiated in a patient who is eligible for NOAC, apixaban, dabigatran, edoxaban or rivaroxaban, a NOAC is recommended in preference to a VKA. This is a sweeping statement which is absolutely new in the cardiology segment, came just 1 month ago, when both are indicated, you choose NOAC by preference. That is something we should ponder about. When patients are treated with a vitamin K antagonist, TTR should be as high, and I don't go into that. But my last slide is that, having said and splitting our hair between VK and non-VK, the ground reality is that still 50% of patients who should be on an oral anticoagulant are not on an oral anticoagulant. So ladies and gentlemen, first settle this issue, how to bring more and more patients under oral anticoagulation who deserve it, and then decide with which to treat. Thank you.
Thank you, Professor Ray. Please have your seat with the chair.